Hello, everyone. Hope you're having a great day. He is Paul Gerard. I am, of course, Kevin Kelly with Gerard & Associates. Check us out at GerardAssociates.com. This is the GNA Way podcast. Thank you so much for listening. Paul, great to see you. Great to be with you.
Same here, as always. Nice to talk with you.
Yeah, and now we can see each other, which is a step up from the audio podcast.
Or down, depending on how you look at it.
We're going up. We're going to coach each other up.
So I can't.
All right, so today we're going to coach up.
Okay, sorry, good.
Today we're going to coach up patient assessment, help you all raise your overall GNA score, eliminate the head fake, so to speak. So let's do it. Let's coach them up. We did some data analysis, and we see some opportunities to close the loop. Some errors in the patient assessment process that could result in better diagnostics and certainly better treatment. So I guess topic number one, the musculoskeletal chest pain that turns out to be angina or an infarct, that we have seen, right?
Absolutely. That's a common one, and that's one of the reasons we picked it as a topic. So we picked three scenarios, but the reality is this happens across all patient care types on some level. And the root cause of the issue ultimately turns out to be that the providers didn't do a complete and thorough exam on their patient. So they went for, as you say, the head fake. They went for the patient, the obvious thing, right? So in this case, a motor vehicle accident, for example, or something of that nature, something a traumatic event occurs, and the patient complains of pain along the rib cage, along the shoulder strap area, and so they just kind of say, okay, this guy's just got some pain from the shoulder strap from the MVA, and they don't go down the ACS assessment route.
Right.
So they don't look for the differentials, right? What are the differentials? So you got a person who's been involved in a motor vehicle crash, they're complaining of chest pain, and is it possible that this guy could be having an ACS event that either preceded the crash and is the cause of the crash, or as a result of the crash and all the stress and anxiety of the incident, they're having chest pain now that's cardiac in origin as opposed to non-cardiac. So very, very common. And, when I talk to the providers about this, they'll say stuff like, oh, yeah, well, we arrived there, and it's clearly along the seatbelt strap location area. It hurts on palpation. It hurts on inspiration. And they stop there. And, I think every experienced medic at some point has learned along the way that using musculoskeletal or pleuritic sounding complaints to determine whether this person should get an ACS evaluation, if not an ACS workup. We've all kind of made that mistake and then eventually learned that that's a very unreliable predictor of whether this person's having a cardiac event. In fact, statistically, a large number of those patients who have musculoskeletal complaints turn out to have a cardiac component to some degree. So, you're playing the odds, right? Statistically,
right.
If you just not, treat that person or at least assess that person as potential for cardiac, statistically, 1 out of every 4, 5, 6 of those patients will turn out to have an ACS event, and then you've missed it. So, common problem.
And what happens when we miss it? I mean, we get them to the hospital, they get diagnosed appropriately at the hospital, they get treated appropriately at the hospital. So we form the clinical impression based on our best guess. What's the harm?
Well, let's walk through that, right? So let's say this is an ACS event and the guy's having, a ischemia or an MI. And you didn't give him his aspirin and his nitrates or his fentanyl or whatever was appropriate for that particular patient. And it took you, 8-10 minutes to extricate the patient from the vehicle, package him, get him in the back of the truck, do whatever workup you did do on him, and then you transport to the hospital. It could take you 15, 20, 30 minutes to get to the hospital. Then, you have to get him out of the truck, get him into the ER, give the ER nurse, maybe even a triage nurse, a report, get him to his room, give another report. The nurse takes that information. She goes, gets the doctor. He comes along eventually, or she comes along eventually, does her assessment, and then says, hey, let's give this guy some aspirin and nitro. So from the time you saw them at street side, where you saw them and you failed to say, hey, let me take that into consideration and do an assessment and a 12 lead and cardiac monitoring and all that sort of stuff, it can be many, many minutes. If the patient is having heart muscle damage, they're going to have 30 or 40 minutes more of heart muscle damage before they start getting their aspirin and their treatment. So what harm is it? The harm is it that the person could walk away with heart muscle damage than they would have had you treated it more aggressively earlier on.
Delayed STEMI alert, missed opportunities to reduce pain.
Yeah.
We kind of look like knuckleheads when we get to the ED.
And again, I've had it happen to me.
Yeah.
When I was a young EMT just starting out, my first week on the job, we did a nursing home patient, and the patient was short of breath and had carpal pedal spasms. And so en route to the hospital, the patient starts complaining of severe shortness of breath. I yelled up to my partner, hey, the shortness of breath is getting worse. This is like 1979, right? This was a long time ago. So we diverted to the local facility, went into the ER, and the nurse said, he's hyperventilating. Here, breathe on a bag, and everything went away. And I felt like an ass, but I learned the hard way that, I jumped the gun. I didn't have the experience at that point or the knowledge. But we've all done that at some point in our career, where we took the ball and ran with it based off of a particular complaint or something that turned out not to be. There's a case that I've mentioned to you in the past, and I'll mention it here because I think it's a really good illustration, is quite a few years back, there was a call where an 80-year-old lady, she has a history of hypertension and diabetes, so she's got risk factors, and she's complaining of upper abdominal pain just below the xiphoid process, upper belly pain, for a couple of days. So calls 911, the EMS providers go, they do an assessment on her, and they say, how long have you had it? And she said, well, I've been constipated for 4 days, but the pain has come on over the last couple of days or so. So the medic said, oh, all right, you're constipated. So they I think they did put a line in the patient, but they didn't do a 12 lead, and they go off to the hospital. So the auditor on our end reviews that call and says, hey, pain above the umbilicus. She's a female, so she's going to have atypical ACS presentation. She's got risk factors in her diabetes and her hypertension. Patient should have gotten a 12 lead. And again, walk that through, right? So we use our scoring system. Our auditor scored that either as a 3 or a 4, a medium or a high risk of an adverse patient outcome, because those calls automatically go to the medical director for a second medical director review, because we want his or her opinion on that. We want them to tell us what they think of that concept. So they scored it whatever it was, a 3 or a 4. They sent it off, said should have done a 12 lead. And the reason they scored a 3 or 4 is, again, if that patient's having a STEMI and they didn't do a 12 lead on her, then the patient didn't get her aspirin and nitro for many, many minutes, if not longer. By the time she gets to the hospital, which could worsen her condition, again, if she's having an MI that is progressing while in the presence of the EMS providers, she could code, have a cardiac arrhythmia. There's all sorts of things that can happen as she continues to get worse because it went undiagnosed. So they scored it as such, sent it to the medical director. And here's the interesting part. The medical director reviewed it, and he said, I can't believe you're recommending a 12 lead for constipation. And he downgraded it to a 0 and said, I'm okay with this. So now, what was your paramedic training, Kevin, for patients with belly pain above the umbilicus? Did they get a 12 lead? You probably learned that in paramedic school.
Back when I went through paramedic school, no.
Well, that's true. Back then, you still had to feed your horse hay to make sure you had the power to get you to the call on time. So
yeah, something similar.
Right. So, but in most paramedic classes, that's kind of a standard approach. Today, and even for quite a few years now, that's been a thing, right? That's not a new concept.
So we wouldn't have obviously put the patient on a 12 lead because we had LifePak 5s back then, but we would have put the patient on the monitor.
Yeah, correct.
We might have done modified chest leads.
Maybe, yeah, because back then we were doing
with that back in the day.
Right.
But certainly, you have a female, and that was big back then. That the 50% of females have atypical ACS presentations, and they need to be worked up.
Right. So, and we know the health system doesn't work up females because for ACS properly.
Right.
We know that.
Yeah. So, absolutely. No excuse for not doing a 12 lead in the field for females with umbilicus pain.
Right. And here's the interesting part of that. So let's talk a bit about the QA process in this, right? So the medical director downgrades to a 0. In our system,
Yeah.
we review every call during trimester reviews with the provider, including all their 0 score calls where everything went fine, because we're looking for the attaboy stuff. If there's one in
Right.
there, hey, nice job on this
Yeah.
call. We're also looking for something like this that started as a 3 or a 4, and the medical director downgraded to a 0, so we can say to the provider, what you did, some people might not want it done that way, but your medical director is, in fact, okay with that. So you don't have to guess or wonder
Right.
or worry whether your medical director would be okay. We have his or her input
Yeah.
saying it's okay. So in a case like this where, my gut, now I can't override the medical director, right? I'm the QA
Right.
guy. Medical director is the king of the hill, and he
That's
or the
right.
queen of the hill, and he or she
Yeah.
says whether it's okay or not me. So when we have the discussions with the provider, it's always good from an education standpoint. It's part of that coaching mentoring thing to say to the provider, hey, let's go over this call. The original audit was maybe you should do a 12 lead on this person for all these reasons. Your medical director goes with the, well, she just constipated thing, so you didn't need to do a 12 lead. However, we don't know whether that was really her issue or not, and you were
Right.
taught in school to do something different. The protocol says you should do something different, right? The ACS protocol gives you a list, and at least here in the local jurisdiction we're talking of, gives you a list of atypical presentation patients in which belly pain is one of them, right? Abdominal
Right.
pain is one of them.
That's right.
So the provider said to me, because this is a really good system where they do a lot of good medicine, and I've been working with them for a number of years, and the paramedics actually like the banter and the back and forth. They like to debate these calls. They actually enjoy the QA process.
Yes, we do.
Yeah, right. That doesn't happen often. So when I sat and met with a medic, and I said to him, hey, Mike, that's somebody who should have probably gotten a 12 lead, but your medical director says okay, so I'm not telling you, to do anything different or anything like that. Whatever, he said, you're good with. But if OEMS came down and investigated this call for some reason, you could still potentially get sanctioned by OEMS regardless of what your medical director says, because the standard of care is that your training as well as the protocol and everything else says that you probably should have done that. So just be careful on those calls. And actually what he said to me, he said, something, in the back of my head there was a brief moment where I thought maybe I should do an honor. And then it kind of passed because I got sucked into the constipation thing. So then we started
Right.
getting into her intakes and outputs and how much she had and how long's it been going on. Is it black and tarry? And he said,
Yeah.
I just went down a whole different avenue and I got distracted from my differential to come back and say, maybe I should shoot that just to make sure. He said, I'll tell you this, if I have that patient to do again, I would do a 12 lead because I actually agree with your auditor on this, that I probably should have done a 12 lead. So to me, that's a great outcome because the paramedic's open, he's responsive. The medical director, again, we can't usurp their authority. Their job is to say yay or nay on these calls, but there have been a lot of cases where OEMS has investigated agencies for calls where they disagreed with the medical director's take on things. And our job is to try to keep paramedics out of trouble, right? So give them whatever feedback we can to help them, prevent them from getting into that situation to begin with. So a better assessment, more thorough assessment, looking past the initial complaint to your differentials, which is what we're talking about today. That's today's topic. That's critical to avoid misses.
Yeah, a lot of traps for the unwary. If you get down the rabbit hole and you don't catch yourself before you get too far. What else, Paul? We
Well,
had, I believe, a case at one point where the clinical impression in the field was vertigo, and my understanding upon transport that the patient actually had a stroke.
Yeah, this is another one that's kind of common. Providers will get to a patient's side, and the patient will give them a soft complaint, let's say, nausea. Oh, I'm nauseous, right? And then the spectrum of potential causes of that range from the benign, just get a little nausea. We all get it. All the
Right.
way to you could be having a STEMI, right? So there's such a sliding scale of potential issues there. And this is another one, right? So a little old lady who's got a little bit of vertigo, feels a little bit of dizziness, that sort of thing. Especially where that dizziness resolves before you get on scene or immediately after you get on scene, and she's now saying she's okay. And so, again, you've got to go to your differentials, right? So you can't just say, a little dizziness. We all get it once in a while. If the patient's saying that she hasn't had a lot to drink today and she was working out in the hot sun, she's probably a little dehydrated. So they fill in the blanks for the patient for all the reasons why they think this is just a simple vertigo that doesn't require any assistance.
Right.
But, and again, it comes back to they didn't do a more thorough and complete patient assessment to determine whether some of the other differentials that could apply here may in fact be applicable. So they don't do much with it. They take it to the hospital. It turns out the patient had a stroke, had a TIA, and then had a further stroke in the hospital. And again, that's a missed opportunity for the provider. It's not great patient care. Now, if you assess that patient thoroughly and completely, and there was nothing else indicating stroke symptoms, her FAST-ED was 0, her stroke scale was, all negative, her neuro exam was all completely positive, everything's positive for how she should be presenting neurologically, then you've got a basis for going on what you went on, right? And if she happens to have a stroke later, that's not your fault. You assessed her thoroughly, completely. She wasn't exhibiting anything that would indicate that that's what was going on at the moment, or that's something that you should potentially be concerned about. So then you might have a bit of a defense. But for all these categories that we're talking, the issue ultimately came down to you didn't have a defense because you didn't do enough of an assessment to prove that some of the other things that could be very serious were not going on with the patient.
Right. So in that particular scenario, you're sitting with the provider and you're going over the data. How are you coaching that provider up?
So the provider works in a complex environment, and they don't always have all the information that they need to make a good decision. So they have to make the decision based on the information that's available to them, and they have to make their decision based on information they should have been able to obtain. And, a lot of times when talking to the provider, they'll say something like, well, the patient was a poor historian, or they didn't speak English very well, that sort of thing. And so when you read the report, you say, well, okay, so if that's a true statement, how did you get a past medical history and know that she doesn't have any allergies if the patient doesn't speak English? And that seems like a pretty intense discussion where they have to have a decent command of the language, or their level of consciousness needs to be adequate. And they'll say, well, I got that from the family member. And I said, okay, so how come you couldn't get from the family member the other information, right? Where's the hole here? So if they don't have a good answer, well, I should have gotten it, then that's the answer, right? But sometimes they'll have a good answer. They'll say, well, the daughter didn't show up until we were just ready to depart the scene. I asked her, we're closing the ambulance doors. Does she have any medical history? Yeah, she got this, that, and the other thing. Okay, see ya. And we kind of headed out. And it just didn't, I didn't have enough time with the family member to get more information because, patient's, pretty sick and I wanted to get him to the hospital, whatever their issue is. Yeah. Then it goes back to, well, you need to document that, right? You need to get that into your story as to that's how things went down, so that downstream anybody reading your report can understand the circumstances that prevented you from getting a decent patient assessment, as opposed to, I just didn't get a decent assessment, even though the resources were there for me to get that assessment, and therefore I missed something. So that's the inexcusable, right? That's the part that people get hung up on and hung out to dry on all the time, is because they just didn't go deep enough into what else could be going on with this patient.
And it sounds like when our team is coaching up the providers, just based on your description of how you talk that provider through, it sounds like the tone that GNA uses across the board is a tone that is much more curious than judgmental. Okay.
That's true. The approach has got to be, I'm trying to understand, help me to understand what's going on with this call. Let's talk about it. And then I almost always say to them, okay, listen, we see this all the time. It happens. It's common. You're not alone in this process. It's an easy mistake to make. Let me give you the tips and tricks that'll prevent you from falling into this trap in the future. As opposed to, I can't believe you didn't do a 12 lead. I can't believe you didn't do a stroke exam. What's wrong with you? You learned this in paramedic school. You should know this. If not stating that, sometimes the body language and the tone of the coordinator says that, even if you're not saying, even if you're saying, you pat on the head, oh, you're a good medic, and I understand where, if your tone doesn't match your words, the provider walks away with feeling like they've been patronized, or that you're not being earnest with them in terms of what you think of them as a provider and whatnot. So we don't go down that road. It's like, hey, man, it's just you and me talking about this call. Let's talk it through. Let's talk about the pros and cons. Let's talk about different options. And then I'll also try to throw in other scenarios. Say, okay, so we just talked about the rule, if you will.
Yep.
You should get a 12 lead in patients with abdominal pain above the umbilicus. But let's talk about some of the reasons why you might not need to do that. And then we'll go into the pertinent negatives, if you will, but we'll go into, some of the other categories of what ifs, right? So these are all the what if questions that providers are sometimes afraid to ask because they don't want to look like they don't know what they're talking about. And so, again, it's that approach, right? So when we talk about it with the provider, a lot of times we'll say, I get what you did. You probably want to do the 12 lead, but let me tell you my thoughts on why I think you should do the 12 lead. And then you tell me what you think of that. And let them say, I disagree with you, Paul. I completely disagree with you. And that's okay. That's okay for them to disagree because who says I'm right? Just because I think they should take a certain approach doesn't mean that everybody else believes that that's the approach that should be taken. So the default is if we can't agree when we talk about this, the vast majority of providers say, okay, I get it. You want me to do a 12 lead on these patients because the pain was above the umbilicus, plus she's got the risk factors, the age, all that sort of stuff. I see it. I get it. I'll do it. No big deal. Let's move on. That's what most. Some will debate and say, I don't think so. I think she was just constipated, and here's all my assessment stuff that verify, that build that case for me. I still think I was right about this. And so when you get to that impasse where you kind of aren't winning them over with your arguments, for us, the fallback is, okay, I hear what you're saying. Let's send this off to medical direction and put that thought process in and see if they're okay with that. If they're okay with that, I'm okay with that, right? They're the medical director. But they might say, no, I agree with Paul, you should do it this way. Or they might say, no, Paul, I disagree with you. I agree with the medic that this was just constipation, doesn't need a 12 lead. And if that's the case, you're okay. Even for the lower scoring calls that we score a 2 or a 1, a documentation issue or a low risk of an adverse patient outcome, those calls don't go to the medical director for a review, generally speaking, unless they meet other criteria, like it was a cardiac arrest or, whatever criteria the medical director wants to see the call just because of what type of call it is. Right. And so if it never went to the medical director and it's just the auditor's comments, I tell that to the provider too. This is just the auditor's thoughts on things that you might be able to do that might improve the patient experience. And we'll debate them. And if the provider disagrees with what the auditor and I'm saying, assuming that we're saying the same thing, because sometimes I don't agree with the auditor either. That's why we put it through layers to get various opinions to discuss the pros and cons of those opinions. And that's where the education part comes in, right? So here's how you could look at it. Here's another way you could look at it. Here are the pros and cons of looking at it that way and acting upon that. Here are the pros and cons of looking at it this way and acting upon that. So even if it's a lower scored item, we'll oftentimes say to the provider, hey, listen, I think you should do it, but I respect your background, your skills, your experience. You're not a rookie. You've got 12 years under as a medic. I get it. Other people would do what you did, and some medical directors might be okay with it. Let's ask the medical director. Even though it's not a 3 or a 4 or it's not a cardiac arrest or any of those things, let's send this up just so we hear from them what they think should be the right answer. Sometimes the provider will say, nah, don't bother with that. I'll just do what you want. Other times they'll say, yeah, no, I want the medical director's opinion on this one, even if it's a minor issue, because they want to know. They want to know so again, don't fall into the trap as the coordinator, the QA coordinator, of forcing your opinion upon this person when other people could have different opinions on this stuff.
Well, it certainly sounds like we're having the courageous conversation with both the provider and if we're not handling the management aspect of this and we're coaching up the CQI provider, that we're doing it in what leaders would call an authentic yet humanistic way.
Yeah.
And the other thing that I am, the takeaway that I'm hearing from you, Paul, is that we're in the moment with these providers. It's us and the provider. We're not in between calls. We're not trying to get this done before the bell rings. We have to go out on another call, like many QI departments are wearing many hats. Matrix organizations, they're being pulled in multiple directions. Some QA people are still on the road. We are not. You have our undivided attention, and this is all we do.
We will spend as long as it takes. As long as the provider wants to keep chewing on that call, we'll keep chewing on that call, right? So we'll keep discussing it. And the conversation can go in all different directions based off of that discussion. It might be, hey, protocol says you should do blah, blah, blah. And the provider will say, no, it says I can do it if I want to, not if I must do it.
Yeah.
And, we'll be like, let's go look at the language of that. Let's go read the language, and we'll open up the protocol, look at the protocol, read the language, say, okay, from the way this reads to me, it sounds like they're telling you have to do that in this set of circumstances. And again, if we disagree, and an example of that used to be the pain management protocol for narcotics in, again, one jurisdiction that we work in. The protocol was give your dosage up to a max of 300 mics of fentanyl, and you can give up to 300 mics. So it said give a dose of fentanyl up to 300, and for a repeat dose, call medical control. So the question was, if you gave 150, didn't give the full 300, do you then have to call medical control to get to the 300, or can you just give up to the 300 before calling medical control, even if it's multiple? Because the way it was worded, it sounded like you couldn't do both.
Right.
So, and that befuddled all of us. The auditors would be like, I'm not sure if they did this right, so they put it in and say, perhaps you should have called medical control for this per protocol. And medical directors couldn't get it right. They would say, my interpretation is, I think they should be able to whatever. And so we would be able to clarify that point with their medical director. So at least if OEMS came down trying to give the providers a hard time, and during an investigation of the call, we could at least say, well, we sent it to the medical director, and he agrees that based on the way the protocol is written, they can do whichever option they chose to do. So again, we try to get them the best answer, not try to force them into compliance that they don't believe is clinically sound.
And the regulatory agencies don't get it right all the time either. We could probably do a whole show on agency miscues and misdiagnosing the error and going down the wrong rabbit hole with the regulatory agency as well, and how we advocate and defend that provider.
Correct. We had, again, a case a long time ago where the providers were gigged by OEMS for 3 issues on a particular call they were investigating, and we reviewed it, and we actually quoted chapter and verse of the protocol saying, no, 2 of those are not applicable here. And they actually did back down and say, we get where you're going with that. Right. They still got banged on the 3rd one, but at least it wasn't as bad, because we were able to say, hey, based on a reasonable interpretation of the protocol and the way it's worded, we don't believe your interpretation is the right interpretation. And, OEMS has got a tough job too, right? They're trying to make sure there's good quality care. There are bad actors out there. There's all sorts of stuff in the media these days, especially about bad actors out there. Yeah. There's pressure on them to make sure agencies are doing a good job, and they don't have a lot of great tools to do that. They usually have to wait until there's a complaint, until something bad happens and somebody complains about it in order to get involved in a lot of cases. And, they want to, rightfully so, hold people's feet to the fire if there's bad stuff happening. So, it's easy to bang on OEMS, right? Oh, those guys, they're not in the field. They're writing these protocols. They don't make sense. But, they've got a very difficult job to do as well. And, again, we see our role as trying to merge all these disparate pieces of the EMS system to get them the best answer for how to handle situations, as opposed to a black and white, you didn't follow ABC protocol, bad on you kind of stuff. Right. So that should be the goal, in my opinion, of every quality improvement operation out there, is helping the providers get the right answer they need to handle things the next time. Yeah,
we operationalize it. That's
Correct.
What we do.
Right.
We take whatever it is, NEMS QA or the statewide treatment protocols of the states that we are in, and we operationalize it. Soup to nuts. We go in and we can handle every aspect of that CQI process. Mm-hmm. We can write your policies. We can do your education. We can do your audits. We can advocate you if regulatory agencies want to take untoward action, which we discussed happens. Right. We're there for you. We're your backup. There is nothing in the CQI realm that GNA could not handle. Mm-hmm. Right. Hey, we got time for another one. You mentioned the stuff in the news, Paul, and altered mental status, alcohol, behavioral hallucinations can easily lead a provider down the wrong rabbit hole.
This one's really timely because of all the cases in the news recently. And this is an area we see. We actually have a report. It's called the Nature of Call report, and we'll look for a given time period, a trimester, for example, and look at all the calls the agency did where the chief complaint or the main issue with the patient was a behavioral issue or ETOH or, drugs or, whatever, overdose stuff, and look at their scoring based on how they treat ETOH patients, for example. So, agencies who, and this happens all the time. It happens every day in every system in the country where there's a provider, if not more, that works for any given agency, excuse me, where they give these people less than their all. So they show up on scene. Oh, this patient's just drunk. We do him 3 times a week. It's always at 2 a.m. He ends up signing refusal when he gets to the hospital and walking stumbling out of the ER, or after he detoxes, he'll leave the ER. He just wants a warm place to stay. He wants a sandwich at the ER because he knows they'll feed him. And they come up with all these reasons why they don't feel the need to properly assess and or treat these patients. And so, for me, this is a category I love to look at because it's very telling of an operation in terms of whether overall that agency has a high degree of compassion for their patients as opposed to not. If they've fully assessed those patients and fully treated them to the extent of whatever their clinical condition was that the protocol requires and got them safely to the hospital, the call gets scored a 0, right? So their scores ultimately are very high. So if they score in the 90, 95 percentile on these patient categories, then there's a really good chance that they're properly assessing and treating these folks and showing at least a reasonable degree of compassion. Usually good patient care and compassion are somewhat correlated.
Go hand in hand.
Yeah, they do usually. So not always. You can do good patient care and still be calling the patient an asshole and stuff, or whatever. Yes, but right. in general, good patient care is somewhat correlated to compassion. Patients, the compassionate approach to the patient. So agencies that have those scores, and I'll tend to point those out, right, when we do our trimester reviews, when we're talking to the group at large or the agency as a whole, and say, hey, look how well you're doing on treating some of these folks who in a lot of systems get underserved. It shows a high degree of compassion as well as good patient care practice on the part of this department, and you're reducing risk tremendously that one of these will come back to haunt you, because these will almost always come back to haunt you on some level. So those are good ways to see whether you're providing. Now, the converse is also true. If they're scoring a 30 and there's lots of 3s and 4s because they didn't do an assessment on this drunk guy who's stumbling around, and they didn't do a blood sugar on him, and they didn't do a stroke exam on him, and they didn't do a 12 lead on him, even though he's complaining of pain all over his body, then you're going to end up getting lots of 2s, 3s, and 4s, and it's at minimum a lack of good patient care ability. At maximum, it's because you don't care, and it's a lack of compassion, and just throwing them on the stretcher and giving them a ride to the hospital. So it's one way to at least get a sense, even though it's not necessarily a tremendously accurate predictor. It's a fairly accurate predictor of whether your folks are treating people with some degree of compassion.
So, big picture, Paul, what do we as EMS providers need to do?
So your QA
what's the call to action here, Paul?
The call to action here is for QA managers, QA coordinators, need to be sure that they're instilling in their providers on every call they review whether there's a proper assessment, including both a full head-to-toe primary, secondary exam as well as a good focused exam. So we see a lot of reports where they did a really good job on the chest pain, but they didn't do a very good job on the rest of the exam to determine if there was something else going on with the patient. And it just so happens that this aspirin nitro that you gave to this particular patient, you get to the hospital and the nurse says, hey, have you had any other problems? Yeah, I've been pooping bright red blood for 2 days. This guy's got a GI bleed, and you just gave him aspirin and nitrates, up the yin-yang. So that might not be the best course of action for this guy. And it's because you didn't delve deeper into doing your full assessment because you thought you had it in the bag with the complaint. Oh, it's stereotypical chest pain, mid-sternum, radiating down the left arm. He's pale, diaphoretic, and sweaty. This guy's an MI. I can read it from across the room. Yup. But the cause is concerning because it may alter how you treat the patient. So you really have to do this. So the key is, if you're a QA person, you really should be making sure when you're reviewing run reports that providers are documenting good reports, in that they're doing the full assessments on patients, especially as it pertains to differentials, to make sure that what they were treating, there's enough data and evidence in the report to support that what they were treating is what they should have been treating, and then making sure that they treat it.
Yeah. And on the provider side, I'd recommend always be a detective.
Yeah.
Don't give up. Keep looking. You have transport times. There's plenty of opportunities to assess, to reassess. Keep an eye on the vital signs. Keep an eye on the monitor. Do your job. Thoroughly assess every patient with a thorough primary, focused, and secondary survey.
Yeah.
Don't get butthurt. I think that's the big one. And I'm speaking for myself back in the day, and probably still to this day. We have a psychology. And that psychology is that we want to help people, and we don't want to do harm. The Hippocrates, right? Do no harm. And when we think we have done harm and we haven't done our best, that hurts us. We get the acid pit in the stomach. We feel bad. We feel embarrassed. We get butthurt. This happens to everybody. One of my famous, still talked about to this day, was a auto versus telephone poll in the town of Milton. Probably a 10-minute drive to a trauma center, and it looked really bad. The patient was altered mental status. I think we had to use the JAWS to get her out. Ended up calling a helicopter. Transported by helicopter to a trauma center, and in the news article, it stated that the patient was discharged 3 hours later with a fractured radial ulnar. So that was embarrassing.
Right.
It was a complete, I don't know what, ego.
So where'd you go wrong, Kevin? Did you not assess her adequately? What was the root cause of your decision-making that made you choose that course of action as opposed to not?
Great question. Thoroughly focused back then on mechanism of injury.
Right.
That was it. It looked bad. It must have been bad. Patient must have been bad. And, the patient's vital signs were stable, but it looked bad. It looked like this patient needed to go sooner rather than later. And ego, anxiety, mechanism of injury led me down a rabbit hole to fly a patient to a trauma center that could have been taken to Milton and discharged a couple of days later.
Right.
So, it happens to everybody.
Right. I've had it happen. Anybody who says it's never happened to them is lying.
I still hear about it. I still hear about that MedFlight call to this day when I run into our old colleagues.
The people who know.
Yeah, so be accountable. Coach up your partner. I mean, that's the other thing that we should be doing as paramedics and EMS providers is we should be constantly teaching and coaching and mentoring our peers. We should have these discussions in the truck. Again, be accountable, but remain coachable. That's, I think, a key takeaway for clinical providers is don't get butthurt and remain coachable.
Right. The details matter. The details matter. Yep.
Yeah.
Okay.
So, what else on this, Paul? In the results from diligent professional patient assessments, we're going to get more accurate pre-hospital clinical impressions. We're going to be able to do more accurate treatment. We're going to be consistent with the statewide treatment protocols. Be more efficient transfer of care at the ED. Less time, and you mentioned this, less time and resources wasted at the ED. Going to increase your individual GNA score. The agency's GNA score will increase. Will avoid embarrassment. There'll be better patient safety. Reduce risk of government intervention from OEMS or other state regulatory agencies. The medical director, reduced headaches for the medical director.
Right.
Public relations nightmares go away.
All of that just off of a provider doing a more detailed assessment to make sure they're not missing anything.
Yeah, absolutely. And these families complain now. When they complain, they don't just write little notes like they used to the ambulance service or complain to OAMS. They get on social media.
Right.
And once they get on social media, that doesn't go away.
Right.
And, lastly, there is a whole quality aspect to reimbursement. Incomplete paperwork gets frequently denied for
Good point.
for reimbursement.
Good point.
And that does not help the agency, that leaking revenue. So
Right.
we have a job to do.
Right.
All right. Well, thanks so much for listening. We hope you picked up a tip or two on avoiding tunnel vision, staying vigilant during your patient assessments, and leaving no stone unturned. We can help your EMS agency reduce risk and showcase your quality patient care. Check us out at GerardAssociates.com. For Paul Gerard, I'm Kevin Kelly. Stay safe, stay in the fight, and Godspeed.
Goodbye, everybody.
Take care.